Bismillahirrahmanirrahim. Assalamu alaikum. Welcome back to the channel, and we are going to continue the tooth surface loss lecture series now. And this is the third video. It involves the process of the tooth erosion. We are going to understand about the tooth erosion, its pathogenesis, risk factors, and a bit about the classification of the tooth erosion. So, what is tooth erosion? Basically, it is the progressive loss of dental tissue by chemical means not involving the bacterial action as a result of the extrinsic or the intrinsic acid. What does it mean? Basically, the tooth structure, mainly the enamel, it gets lost due to the presence of the external or the internal acids uh, through the process of going down pH below the critical level. When pH goes below the 5.5 mark, that is the critical pH, the demineralization of the structure, it starts basically the enamel, and we are going to see the demineralization of the tissue that is not due to the bacterial action, and it is due to the chemical action. So what is the pathogenesis? There is a brief understanding. This is basically a microbiologically sterile process, and as such is very different to dental caries. There is no involvement of the bacteria in this, and the structure gets resolved due to chemical insult only. So if you see the enamel structure, basically it consists of the calcium and phosphate. The structure is known as hydroxyapatite, and it mainly forms 97% of the tooth enamel, and it exists as a supersaturated liquid phase. This is very important to see. It exists as a supersaturated liquid phase surrounding the hydroxyapatite crystallites. So here we will see the saturation, how saturation goes up and saturation can go down to initiate the process of the demineralization. So the solubility of hydroxyapatite, basically it depends upon the pH value. What is pH? Basically, it is the level of the acidity inside the oral environment. So when the ambient pH it goes beyond the critical value, the process of demineralization it gets starts, and when it goes above the pH values, above the critical pH value, the ions can be retaken by the structure of the tooth, and it can get remineralized. So this is the basically a seesaw, we can say supersaturation and saturation. So when the pH value goes down, the structure gets dissolved, and when the pH value goes up, it can get repaired as well. So at low pH value, you can see here below the critical pH, a high concentration of ions is needed in the liquid phase surrounding the crystallites to maintain saturation. We have discussed in the previous slide regarding the saturation. So if there is a higher concentration of ions needed to maintain the liquid phase surrounding the crystallites, then the process of demineralization it can happen, and it happens below the critical pH, that is 5.5. And so the driving force is towards the dissolution or the dissolving of the enamel structure. And similarly, if the pH is high above the critical value, there is need of a lower concentration of ions to maintain the saturation, and it goes towards the precipitation, we can say, or the remineralization of the structure. So the aim should be to maintain a high pH value, and that is provided with the salivary enzymes and the presence of much needed saliva, or the you can say that a good quantity of saliva to buffer the effect of the pH or the acids that are coming inside the oral cavity. At a neutral pH, this equation is in balance. You can see. So there is resolution to the right of the equation in that equation, and similarly precipitation also occurs. So the aim should be to maintain a high pH value and to prevent the low pH values. And low pH value, that happens when the chemicals are more inside the oral cavity, and the process of erosion can start. Now, if the frequency of the low pH events is high, redeposition of the mineral is not complete before the next demineralization episode, leading to the cumulative loss of the enamel substance. If the pH is lower down in the oral cavity for long periods, you are taking anything like some carbonated drinks or something high in acid content, then the balance is not maintained, and there is a collective loss of the enamel substance, and erosion or the erosive cavity can develop. So the reactive fluoride ion can substitute for the hydroxyl and the carbonate ions, making the hydroxyapatite less soluble. This is very important, and the phenomena is known as mature enamel. You have discussed about that. So when hydroxyapatite uh, is then the hydroxyl ion in the hydroxyapatite is taken up by the fluoride ion, and it becomes the fluorapatite. Becomes more compact, and it becomes difficult for the acid to remove the fluoride ion from there. So erosion can be prevented with the help of the fluoride ion, and the reactive fluoride ion can substitute the hydroxyl ion and makes the hydroxyapatite structure to fluorapatite structure, and in that way erosion can be prevented as well. So incorporation of the carbonate makes it more soluble, while the fluoride ion results in the less soluble product. So fluoride is beneficial to prevent the erosion. In this chart, you can see that the acid intake, when acid is high in the oral cavity, pH drops and it dissolves the calcium and phosphate. And when saliva becomes ample, so pH rises. In the presence of the saliva, you can prevent the process of pH going down and causing the demineralization. If fluoride uh, presence soft structure is repaired, forming the mineral surface. Similarly, if there is presence of the fluoride ion and it can replace the hydroxyl ion, then the structure is repaired and the mineral surface becomes more compact, and it requires more pH drop to demineralize the structure. So erosion can be prevented in this. Now, what is erosion? The repeated acid attack removes the pellicle protection, even the pellicle layer that is formed within seconds on the structure of the tooth. So when the repeated acid attack is there, you are taking more drinks, or you are taking like more spicy food or more food that is lower in the pH, or you have gastroesophageal reflux disease or any other internal cause that is causing the pH in the oral cavity to go down, then the pellicle protective layer that is also removed, and it allows the acid to contact the tooth surface. And acid easily displaces the saliva, as well as acid has a low surface tension and hence the contact angle. So it can easily, you can see the demineralization front here, the advancing front or the demineralization front here. When the acid is in ample amount for ample period of time, then it can easily displace the saliva, the protective layer of the saliva, or the protective action of the saliva, or the buffering action of the saliva, that is removed due to the lower surface tension of the acid, and it attacks the surface and removes the ions and causes demineralization. And the acid causes rampant demineralization of the tooth surface, producing a dished out appearance. A dished out appearance is formed, that is also like a polished appearance, and leaving that is important, leaving a thin enamel layer closest to the gingival margin. That is the landmark of the tooth erosion process. So this is the whole process. Here you can see the pattern of the caries on the left side, and the wedge-shaped defects or the brain cavities in the middle, and the erosion with the intact enamel adjacent to the gingiva. That is the very important. Erosion with intact enamel adjacent to the gingiva. There will always be an intact enamel surface adjacent to the gingiva. On the gingival margin, there will be intact enamel surface in case of tooth erosion, whether it is mild, it is moderate, or advanced stage of the tooth erosion. Now, what are the risk factors? Risk factors can be divided like factors on the patient side and factor on the nutrition side. On the patient side, eating, drinking habits are there, tooth cleaning habits are there, medication and the saliva, and there are also the different conditions like the reflux diseases, bulimia, pellicle formation, soft tissue conditions. And on the nutrition side, you can say acid attack, buffering, adhesion, phosphate fluoride. These are all the factors, and socioeconomic status is also there. Now, what are the nutritional factors? Dietary items with erosive potential. What are these? Beverages, carbonated or fizzy drinks. These are very much involved in the tooth erosion process. Pure fruit juices like orange juice and different other juices, they are also the cause of tooth erosion. Alcoholic drinks are there, herbal teas are there. Regarding the foods, citrus fruits, grapes, apples, sauces like ketchup, brown sauce, snack food, salt and vinegar crisps, vinegar and pickled foods, pickled products, they are also there. So these are all the beverages and foods that can cause tooth erosion. So nutrition factors, how they influence. Chemical factor influencing the erosion potential of the foods and beverages. pH and buffering capacity. Their adhesion of the product to the dental surface, dilating property of the product, calcium concentration, fluoride and phosphate concentration. So buffering capacity, that is very important. Buffering capacity is the ability of the acid solution to dissolve the enamel or the dentine is associated with the undissociated acid in the drinks and foods. So the buffering capacity is very important, and that product which causes the pH to lower down below the 5.5 level or the critical pH, it can also cause erosion if it is in contact with the tooth structure for a greater period of time. So the greater the buffering capacity of the drink, the longer it will take for the saliva to neutralize the acid, and then the more appetite will be dissolved and tooth erosion will occur. Nutrition factors. The concentration of the calcium, phosphate, and fluoride in the drink or food plays an important role. And whenever there is fluoride, it can form fluorapatite and it can delay the process of the tooth erosion. And similarly, a low grade of undersaturation leads to an initial surface demineralization, which is followed by the local increase in pH and increased mineral ions content in the liquid surface layer adjacent to the tooth surface. This layer can then becomes the saturated with respect to tooth mineral and does not demineralize. So this is very important. Now patient factors, the behavioral factors are there, eating habit, drinking habits are there, unhealthy lifestyle where diet high in acidic content is there. So frequent consumption of alcohol and designer drugs. Similarly, nighttime baby bottle feeding with acidic drinks. That is also important. Oral hygiene practices are the most important in all type of tooth surface loss causes. So patient factors, gastric acid may, there is GERD, gastroesophageal reflux disease. If there is reflux of the acid from the stomach towards the oral cavity, it can be more harmful. And different diseases are there, esophagitis, hiatus hernia, in pregnancy, this can also happen. And drugs like diazepam or neuromuscular conditions like cerebral palsy, increased gastric pressure like obesity, pregnancy, ascites. These are also the cause of erosion, and increased gastric volume after meals, obstruction or spasm. These can also result in reflux of the acid inside the oral cavity. So there are three conditions. Rumination, that is the ability to relax the lower esophageal sphincter, reflux acid content in the mouth and re-swallow. This is a condition, this is a disease, this is a behavioral disease that is present in some individuals, and rumination can destroy the tooth structure. Similarly, bulimia nervosa and anorexia nervosa, these are the psychiatric conditions as well. So bulimia nervosa, what is this? It is characterized by a persistent preoccupation with body weight and shape and periods of uncontrolled eating. A patient is suffering from obesity and he or she wants to lose weight, but they cannot resist the temptation to uh, eat or get snacks every day, every hour. So what happens? They uh, consume large volumes of food, and then after they cause self-induced vomiting to prevent the weight gain. In that condition, when the products are uh, travel from the acid to the mouth, and they can increase the pH value, and this acidity can destroy the tooth structure and cause tooth erosion. So that is bulimia nervosa. And similarly, anorexia nervosa, it is extreme weight loss from a self-imposed and severe restriction of foods and fluids and self-induced vomiting as well. We have already discussed the factor of the saliva, and similarly, it can prevent the formation of the erosive lesions, and it can increase if the salivary flow is low. And in that condition, if there is reduced clearance of dietary acid due to low production of saliva or the low flow of saliva, it can cause erosion. Similarly, reduced buffer capacity can increase the process of the demineralization and increase the process of the tooth erosion. And xerostomia is very important when there is low or no production of saliva, then it can cause huge erosive lesions in the oral cavity. This is the diagram which shows the different type of the erosion cavities. So that is advanced generalized pathological tooth surface loss in a 79-year-old female with major attritional and erosive components where has been exacerbated by the recent history of xerostomia. So their patient is affecting from xerostomia and all the surfaces are destroyed, and you can see a thin area of enamel around the gingival margin. That is the landmark of tooth. Now comes the patient factor, occupation and sport. That is also important. All the employees of the chemical industry or the professional wine tasters, they are at high risk of erosion. Similarly, professional athletes taking high concentration of fizzy drinks or the sports drinks, they are at a liability of get affected from the tooth erosion. Similarly, swimmers, as you know, the swimming pools, they are cleaned by chlorine, so swimmers can get affected by acidic attack. And excessive exercise, excessive exposure to water or sports drinks with low pH or increased GERD resulting from the strenuous exercise may be responsible for the sport-induced erosion. So sport-induced erosion, that is another term, and it is drugs can cause that, medications, illegal drug use, and a great factor is the use of ecstasy or the methamphetamine, and it causes a condition known as the meth mouth. So meth mouth can also cause uh, erosion lesions. It may include rampant tooth decay, drug-induced dry mouth, teeth grinding, and a craving for the carbohydrate and sweet. Clinical signs and symptoms. So this is classified as mild, moderate, and advanced lesions. So mild, what is the mild lesion? Characterized by the loss of enamel surface, like there are lines and ridges, and leading to the polished, smooth, silky glazed appearance. And again, there will be a thin enamel remaining around the gingival margin. Opacities can develop, white spots, thinning of the enamel, and it is not usually associated with pain or sensitivity. The mild form is not usually associated with pain or sensitivity, and there is intact enamel along the gingival margin. In moderate condition, there comes the flattening of the bicuspid or molar crust and the consequent loss of the vertical dimension. So vertical dimension is also lost, and lesions progress and cause cupping and grooving of the ocular surfaces. And in moderate condition, there will be increased pain or sensitivity as well. And in the advanced lesion, there will be existing respiration appear to stand proud. The tooth structure uh, get lost or demineralized due to the erosive attack, but the cavities, but the restorations like amalgam restoration and the restoration, they are not affected by the acid attack. So structure of the tooth gets lost, but the restoration, they stand in their previous position, and the term is used to stand proud of the surrounding tooth structure. So amalgam restoration commonly appear clean and untarnished. So this is a landmark of advanced erosion. And even when the enamel loss is widespread, the preservation of enamel cup in the gingival crevice or the margin area is common. That is the landmark of erosion. If the erosion progresses slowly, there will be deposition of tertiary dentine, causing a narrowing of the pulp chamber. So narrowing of pulp chamber can also be seen. And if the process is rapidly progressing, it may result in the exposure of the pulp, and there may be need of the root canals there through thin occlusal enamel. So narrowing of pulp chamber can be there, and exposure of pulp can also be there, and proud restorations they are seen in the advanced lesion of the erosion. So that is all for today. Inshallah, we will come with the next lecture soon. So if you have any question or query, you can ask in the comment section, and do share the video with your friends, and do guide us regarding the improvement of our lectures in the next sessions. Thank you very much. Allah Hafiz.